Hi everyone, good evening and welcome to the Terumo Learning Edge Radial First Go Everywhere with Glidesheath Slender. My name is Jennifer Masabini and I am a Senior Education Manager here at Terumo. I'm joined here with my colleagues Ellie, Ilka, Yara, and Sydney supporting the virtual side of this recording. I have a few housekeeping items that I would like to go over. First, this presentation is intended for US physicians only. Products may not have regulatory approval in all countries, so please contact your local sales representative if you have questions about the availability of products in your area. This will be a recorded roundtable discussion, so if you have any questions regarding the topics discussed or looking for any further Terumo education opportunities, please visit us at www.terumois.com or reach out to your local sales and clinical representatives. We have a great event planned this evening, and leading the discussion will be Terumo Senior VP, Chief Medical Officer, Dr. Michael Martinelli. Dr. Martinelli is an interventional cardiologist with over 20 years in practice, and I would say probably one of the true pioneers in radial access. So with that, thank you all for joining us tonight. And Dr. Martinelli, the floor is yours. Thank you.
Thanks, Jen, and hi, everybody. And thank you for giving us your time this evening. We have a real esteemed panel to discuss something that's near and dear to our heart here at Terumo, and that's radial access. First, we'll start out by making some introductions. So why don't we go around the horn and introduce ourselves. I'm Mike Martinelli, as Jen said. I'm the Chief Medical Officer for Terumo. My experience is in interventional cardiology. And then we'll go to Dr. Peebles.
Hi, I'm Todd Peebles. I'm a neurointerventional radiologist in Wisconsin. Been doing neurovascular procedures through the wrist for about 6 years.
Great. And Dr. Resnick is next.
Hi, I'm Dr. Neil Resnick. I'm an academic interventional radiologist in Atlanta, and I've been doing radial access for just over a decade now, 2012.
Great, welcome, thank you. And Dr. Zhiroff.
Good afternoon, I'm Katrine Zhiroff. I'm an interventional cardiologist in Los Angeles. I've been doing coronary procedures through the radial since 2012 and peripheral vascular procedures probably in the last 5 years or so.
Thank you. And last but not least, Dr. Skripochnik.
Hi, Eddie Skripochnik, vascular surgeon in New York, New York Presbyterian, Columbia. I've been doing peripheral interventions from the wrist since about 2016-ish.
Great. So we talked about a little bit about the snuff box, and I like to get a little bit more insight into the snuff box. I think I certainly agree that with use of the distal radial artery, ultrasound is essential, and I think this is going to be unique to each specialty. So maybe I'll start with cardiology because I'm familiar with that with Dr. Zhiroff, and ask you about, what do you feel the role is? And this could be just specific to cardiology, obviously. What do you think the role is, or if there is a role, for distal radial access?
Frankly, I think it's in cardiology more of a niche procedure. It's almost like I can't really find a consistent reason why for a cardiology procedure you would need to use the snuff box. I think some people argue that it's more comfortable for the patient if you're doing left wrist access because the hand is in a more natural position. I think it makes it for a slightly longer access, which I'm sure gets faster as you use this procedure more. But again, I haven't really had a circumstance where the positioning of the arm was an issue for like a long case where you're doing left radial access. So, I don't see it as being a widely used access point for cardiology procedures, and definitely not for anything that's urgent or emergent.
Or I would say even complex, because it's a smaller vessel.
Right.
You're not going to be doing 7 French. Access.
Right, and you have limited upsizing capability.
Right.
Yeah.
How about closely related vascular surgery access from the distal radial?
No, I think for vascular surgery, especially peripheral, every every inch matters. So, every centimeter matters. So I would stay away from it. I actually never have done a snuff box access for a peripheral intervention. I don't see why, other than maybe I agree with positioning, but I've never had that kind of issue either.
Great, thanks. I think we're going to hear from the other side of the fence on this. How about Dr. Peebles?
Yeah, I started doing snuff box access mainly because it was associated with a lower occlusion rate, and that was my primary goal there. And I think the other things are true about more anatomic arm positioning and so forth. And that's the primary reason I use that. I want to avoid the scorn of cardiology when I if I close off the radial artery. So I don't want to be that person. But it is absolutely true that even in neuro cases where the vast majority of the time you can use all your standard equipment from the snuff box approach, there are occasions where you run out of length and you wish you had back those few centimeters that you gave up in going distal. And also it's the truth in the size of the sheath that you can introduce can also be a limitation in some cases.
Sure. How about Dr. Resnick? Anything to add to this?
Yeah, no, to me, and I understand that the point Dr. Peebles made, but it feels like a solution in search of a problem. To me, it's just like in vascular surgery, and we often will go peripheral, but we'll also do prostates and other areas where we need length, and so for us just to go more distal and to go to a smaller vessel, it just doesn't, to me, seem like something I need to do. And in fairness, I haven't done it all these years, and have never wish I had. Otherwise, I would have started doing it. And as far as positioning goes, I think you just have to be really careful that you tape the palm and not the fingers, and those kinds of things to make it more comfortable. But I've never had a patient say that they were uncomfortable or start moving around because of that.
I mean, I think the one thing that always comes up with distal radial is the radial artery occlusion, and there's studies that have shown that it's improved with distal radial. I think there was just a meta-analysis that was published a few months ago in JACC Interventions that showed that there was probably a slight decrease in radial artery occlusion. But it sounds like from this group, if you use best practices, anticoagulation, hydrophilic sheath, patent hemostasis, and all the things that we know and love, that we could probably get that rate down to below 1% in the traditional. So I think that I agree with everybody on that. Anybody have anything else to add with regard to the radial artery occlusion? We don't get any, right?
Sometimes in the IR world, and more so when we used to do a lot of TACE, we still do some, but you'd go in multiple times and do multiple procedures, every 6 weeks or so. And in those settings, I would see, kind of more of the radial artery occlusion. It was silent, but as long as you took care and all that. But my only advice in those cases is if you're going to be going back in multiple times in the future, then you could even either start a little more distal and then just each time just come like a centimeter more proximal or half centimeter more proximal, but try not to hit it exactly in the same spot. You've got plenty of room to go. That'd be my only advice.
Great, thanks. Well, thanks so much, everyone, for all your time and your expertise. We really appreciate it. I think that these types of discussions are really beneficial for our audience, and we're certainly grateful to have real champions like yourselves. So thank you very much, and we really appreciate all the time you spent.